This talk was part of a Magnum stitching course, a basic Magnum stitching course devoted to diagnostic criteria and multiple sclerosis. And as you know, the panel is now being summoned, so they are discussing possible changes to the 2017 criteria for a new set of diagnostic criteria and multiple sclerosis. So in this teaching course, what we wanted to do was to go through the previous criteria, but also suggest the possible changes that will come in the future. And in my talk particularly, I address this from the point of view of a clinician. And I summarize the different aspects that we believe they should be changed. One, and there's a lot going on at ECTRIMS this year over the inclusion of the optic nerve as a topography. This is, you can say this very quickly, as I've done just now, but there's a lot of work behind to make sure that the way that this topography is incorporated is the right one, is sensitive enough, specific enough, and so on, whether we should just assess this with MRI, or we can also get the help of OCT and evoke potential, and the role of clinical findings on top of that. That was one key point, and if I just need to summarize, the second key point was the try to increase the specificity of the MRI findings by describing some features of the lesion, not just the topography, so the location and the shape. And among these, I think there are a few that may be relevant, and particularly the central vein sign, and also maybe the paramagnetic rim lesions. I think particularly for the central vein sign, there's already evidence being gathered. In my impression, it's a bit lagging behind the optic nerve story, but it would be good if we could get this sorted as soon as possible. And the other thing, and the final key point that I would like to raise, is the radiologically isolated syndrome story. I think for some patients, provided that your neuroradiologists do good in interpreting what is being seen in the MRI, we have confidence enough to say that these patients, even without any clinical findings or any clinical symptoms, they have a mess. So I think we need to work on that, not to exclude them from diagnosis first, and then, if needed, therapy.